Hello guys, myself Dr. Aditya Prasad Padi. Welcome to our channel, The Surgery Times. Follow us in Instagram, Telegram, Facebook as well as in YouTube. So our today's topic is gastrointestinal stromal tumor, that is GIST. It is very important topic, very important. So utilize the video, like, comment and share. And let's start the topic. So it is a very rare neoplasm, that is 0.1 to 3% of all GI malignancy. Important, rare. And it is most common non-epithelial tumor in the GI tract. And most common site is stomach. Okay, these are first three important MCQs. Okay, so in stomach 56%, whereas followed by small bowel 32, colon, rectum 6, and esophagus is 1. Less than 1%. It is very rare in esophagus. Okay, now its origin is from the mesenchymal tissue, that is interstitial cells of Kajal, which expresses both CD34 and CD117. So these cells are the pacemaker cells which intercalates between smooth muscle cells and intramural neurons. Okay, so it is a very important question. Now, male equal to female 1:1 ratio, and most commonly in the older age group 50 to 70 years. And it is nestin positive 90 to 100%, whereas CD34 positive in 80% cases. These are the markers for this tumor. And classification, there are mainly 4 types. Along with size, we have to see for mitotic divisions. Activity. So as per sizes, very low risk is less than 2 cm, low risk is 2 to 5, intermediate is 5 to 10 cm, whereas high risk are more than 10 cm. So joins to modification National Institute of Health considers classification. Hard to remember, but you can see the tumor size are same as we have discussed, whereas overall mitotic index are less than 5 for very low and low, whereas intermediate is above 5, okay, and high risk is any or above 5. Okay, you can go through this and remember accordingly. Next is histological types, mainly 3 types, and more common is spindle cell, that is 70%, followed by epithelial, and combined is very rare. Now clinical presentation, as it is occur in the GI tract, most common is GI bleeding. It is a very important MCQ. Other clinical features like abdominal pain, weight loss, large abdominal mass, if the size of gist is increasing, and also it may cause obstruction as well as perforation. Okay, intestinal obstruction, perforation. Next important question is Kernistride. It is a combination of extra-adrenal paraganglioma, pulmonary chondroma, and gastric gist. So if you are diagnosing a patient with gist, then you should look for extra-adrenal paraganglioma and pulmonary chondroma. But it is not that 100% gist cases will be associated with other two. Kernistride, all the 3 factors, gastric gist, pulmonary chondroma, paraganglioma, is present around 22% cases. Now investigations. Investigation first is by endoscopic ultrasonography guided FNAC or biopsy, and that is true for less than 2 cm size, because large sizes there can be high chances of bleeding also occurs. Now CCT abdomen pelvis can be done in order to see the exact site, size and exact location. Endoscopy also already I have discussed. MRI can be done. 18 FDG in case of difficult or equivocal cases if you are confusing between benign or malignancy. And immunohistochemistry like CA19 CES, AFP alpha beta protein can be done. But ideally endoscopic ultrasound or CT scan. Okay, these are main important things. Now tumor markers, there are 2 tumor markers like c-KIT and PDGFR, platelet-derived growth factor alpha. CD117, there are exons like 11 or 8, 9, 13, 17. Out of this, 11 is most commonly mutated. Whereas in PDGFR, exon 18 is most commonly mutated, followed by exon 12 and 14. Okay, we have to remember this. These are very important for MCQ point of view. Now treatment can be surgical, endoscopic, medical as well as radiotherapy. So surgical, it can be open, it can be laparoscopic. But before surgery, you should know the principles of surgery. This is very important MCQ point of view, also in case of practically. So resection of the tumor along with adjacent bowel. If you are going to resect the tumor, along with adjacent bowel should be resected. And resection should be R0, means no microscopic or macroscopic, lymph node should be left and without rupturing the pseudocapsule. This is also very important because surrounding the tumor one pseudocapsule is there. So you should not rupture it because high chances of metastasis inside the abdomen. Okay, and complete resection with at least 1 to 2 centimeter gross margin is required while operating a case of GIST. Now open or laparoscopy. So open, what all choices are there? Primary wedge resection of the tumor, partial or total gastrectomy, pancreatic or duodenectomy, APR abdominal perineal resection, and cytoreductive surgery for resectable advanced or metastatic diseases. So as per the location and as per your choice, you should go for the options given. Now laparoscopy, lap assisted resection should be done for small tumors like less than 2, and laparoscopy is highly not recommended for more than 5 centimeter diameter. So here tumor locations as per the and the technique what you can do. Like they are divided into 3 types: type 1, 2, 3. So type 1 is basically in the fundus as well as greater curvature. So here if the tumor is located, then you should go for lap staple partial gastrectomy. In case of pyloric or antrum, if the tumor is present, then lap distal gastrectomy. Whereas if it is present near the lesser curvature or gastroesophageal junction, then you should go for lap transgastric resection. Okay, if a question will ask history, with a history, if diagnosis is GIST and tumor size is 1.5 centimeter located in the pyloric region, nearby pyloric. So what is the surgery of choice for this case? So as it is less than 1.2 centimeter, then you should go for lap. Pyloric region means lap distal gastrectomy. So like this, the MCQs also can be asked. So endoscopy full thickness resection should be done, and along with endoscopy, lab also can be collaborated. So medical management, there are 2 drugs, actually 3 drugs, newly added one I will tell, regorafenib. So most common is imatinib mesylate, that is most sensitive, most commonly used, and it is most effective. Okay. So main thing is we are clinically used imatinib mesylate also only. So next, systemic therapy with biologic agents. So imatinib mesylate, otherwise called as Gleevec, orally it is given. Tyrosine kinase inhibitor, all are TKI. All drugs are tyrosine kinase inhibitor we will study. It prevents phosphorylation. Most common side effect also is once asked in the NEET, diarrhea, fatigue. So indication of imatinib mesylate if more than 10 centimeter tumor size, intraperitoneal tumor rupture if occurred during surgery, and up to 4 peritoneal metastasis. Sunitinib, it is also a tyrosine kinase inhibitor and active against KIT, PDGFR, BRAF genes. Now newly added is regorafenib. It is also same mechanism of action, and it is currently approved by FDA, NCCN, and other guidelines as third line therapy. Okay, because first is imatinib, sunitinib, then regorafenib. Okay, now it can be used as a continuous therapy with the imatinib for 1 to 2 years in the post-operatively in order to reduce the recurrence rate. Got it? Now radiation therapy. So usually previous articles you can see radiation therapy should not be done because these are radio resistant. It has been proved. But nowadays what happened, also many practically they have seen only the radiotherapy can be used for palliation in bone metastasis. This much is the rule. Okay. Now this is a flow chart showing how you will manage a primary or recurrent GIST. So if you are finding a primary GIST, then and no metastasis, then go for surgery R0 R1. Then if R1 is present, imatinib or observation as per the size also. Okay. Now if the surgery R2, so R0 is microscopic or macroscopic, not visible. R1 microscopic. Okay, whereas R2 macroscopic also if visible. So if R2, then go for imatinib. Okay, now if the primary GIST metastasis are unresectable, okay, in such places it cannot resect or neoadjuvant therapy given, then biopsy should be taken followed by imatinib. Okay, if the patient having recurrent GIST, then first go for neoadjuvant, that is imatinib. If it is responding, then you see along with imatinib, surgery can be done. Instead of imatinib, it is progressive, then second drug is sumatinib. Okay, accordingly we will treat the case. Now follow-up. Follow-up, if the patient comes to you, then history, physical exam, and CT abdomen also done. How? So you remember this one. CT scan every 3 to 6 months for 3 to 5 years, then annually. Okay, it should be done. Now a few points I will tell you. So most common metastasis, peritoneal and liver. Lymph node metastasis very rare. Small tumors in the stomach are most common and unnoticed unless any GI bleeding occurs or pain abdomen, nothing. Then you should not go for surgeon or any investigation. That's why small tumors are always unnoticed. How will you recognize? By tumor ulcer bleeding, incidental endoscopic finding, or non-specific symptoms like abdominal pain, weight loss, and some doctors will advise you ultrasound followed by further investigations. You find out it as a GIST. Now, cellular proliferation index, I will tell you just 2 points. KIT exon 9 mutation are more aggressive as compared to 11. Second is ruptured GIST. Nearly all ruptured GIST show the abdominal metastasis. So, you should not rupture the pseudocapsule. So, this is how we discussed everything regarding the GIST. So, you can utilize the video, like, comment, and share. Okay, and subscribe our channel, The Surgery Times.